Hello, my name is Henry Steplin, and this is my journal club. My topic for discussion is the evaluation of once a day tobramycin regimen to achieve target concentration in adult patients with cystic fibrosis. Cystic fibrosis is an autoimmune disease or genetic disease which affects the secretions and mucus secretions, and the mucus secretions become more stickier and more thick and are thicker, which causes lung issues and GI issues. The presence with lung issues, you have a presence of Pseudomonas aeruginosa for infections, and aminoglycosides is the drug of choice for the treatment of this one. Tobramycin is our drug that we're studying, and for optimal clinical outcomes, we look for a peak concentration of a peak concentration that is 8 to 12 times higher than the minimum inhibitory concentration, and the minimum inhibitory concentration is the ratio of the Cmax divided by the minimum inhibitory concentration, and this ratio gives us the coverage of the drug. And therefore Pseudomonas aeruginosa is 4 milligrams per liter, and for 10 times more than 4 milligrams we come with 40 milligrams per liter, and this gives us our target concentration of 30 to 40 with the difference of 10 milligrams per liter. Patients were dosed at 10 milligrams per kilogram per day, and they all had to include cystic fibrosis. The objective of the study is to evaluate success of an initial dose of tobramycin dosing regimen to achieve target peak and trough concentration in adult patients with pulmonary exacerbations of cystic fibrosis. The trial design was a retrospective single-centered medical record review, with the location being a large tertiary care academic medical center. The inclusions of the study: the patients had to be at least 18 years of age, had a diagnosis of cystic fibrosis, received initial IV tobramycin dose of 10 milligrams per kilogram per day, and had at least 2 tobramycin serum concentrations. And in the encounters, the same patient can be included in the analysis more than once. Evaluation of exclusion was devaluation from the tobramycin dosing regimen, undetected serum tobramycin concentration, baseline history of end-stage renal disease requiring dialysis, history of lung transplant, pregnant if a patient is pregnant, and children were not included due to the setting being a hospital. It was a total of 186 patient encounters that were reviewed and that were selected, and 112 with cystic fibrosis were treated for acute pulmonary exacerbations with the initial dose of 10 milligrams per kilogram per day. The study took place from January 1st, 2009 to December 5th, 2013. The primary endpoint was to evaluate the success of the initial tobramycin dosing regimen in attaining the target concentration. Target concentration was the target peak concentration was 30 milligrams per liter to 50 milligrams per liter. A secondary endpoint was the achievement of the target trough concentration, and achievement of the target trough concentration, which was the target trough concentration is below 0.05 milligrams per liter, achieved of combined peak and trough targets. So if they achieve the peak and the trough, and incidence of nephrotoxicity, which is the leading one of the leading adverse effects of aminoglycosides. The follow-up period consisted of, there were 3 drawings on the first 3 days of the regimen, and 2 hours after the first hour infusion, and approximately 2 hours after the first hour infusion. Tobramycin Also had a random concentration drawn 8 hours after the end of the infusion. There were a total of 322 patient encounters that were screened, but only 182 unique patient encounters were selected, with 112 being involved in the study. The arms of the study was patients with cystic fibrosis with a BMI of 18.5 to 24.9 kilograms per meter square versus the lower BMI, which is less than 18.5 kilograms per meter square. Both groups are treated with the initial dose of tobramycin and evaluated for the achieved target dose. The initial dose was 10 milligrams per kilogram per day, and with a peak concentration of 30 to 50 milligrams per liter and a trough less than 0.05 milligrams per liter. The study analysis for this study was bivariate and multivariate, and it was used to evaluate the association with achieving target concentrations. Baseline characteristics. The results. 42 of the patient encounters met the combined peak and trough targets with initial dosing regimen. Target tobramycin peak concentration of 30 to 50 milligrams. 41% of the patients met that of the target peak, with the mean peak of 28.9 of all the patient encounters. 55.9 were subtherapeutic peaks, which was below, and 2.7 was super, which was above the 50 milligrams. Secondary endpoint was target tobramycin trough concentrations of 0.05 milligrams after the first dosing. It was a mean trough value of 0.15 milligrams per liter for the trough concentration among the encounters, with 62.4, which was 116 patients that actually achieved the trough concentration. Adverse events during this trial was 10% of the patients encountered nephrotoxicity, which is, with my primary study literature, the dynamics of aminoglycosides is one of the commonly adverse effects of aminoglycosides. The author's conclusion is the current initial tobramycin dosing regimen for patients with cystic fibrosis, recommending an empirical dosage of 10 milligrams per kilogram per day, does not reliably achieve target peak concentration. Approximately 10% of patients experiencing nephrotoxicity with the current initial dosage. Optimization of the initial cystic fibrosis tobramycin dosing regimen is warranted. The strengths of this trial. Is definitely in acquiring a regimen for tobramycin dosing with cystic fibrosis is getting us a step closer, and the child can be repeated with closer parameters. It's a trial that can be continued for guidelines of cystic fibrosis treatment and exacerbations. The strength is the effect. We know the effect of the 10 milligrams per kilogram per day of tobramycin dosing on target demographics, and we can use that, and it can be used. The information can be used to assess the next study, and so where we can expect better outcomes. The weaknesses of this trial, of this experiment, was it was in a single center, which allows for not too much diversity. The dose changes in some of the patients was received higher than necessary, so it was outside the regimen and the guidelines. The MIC values were not recorded. With the MIC, the minimal inhibitory concentration values being recorded, we can see if the peaks and the troughs actually relate to the coverage and the efficiency of the drug. With the MIC, we can actually see the effect of the drug, and then compare it to the demographics classifying the weight and expected trough levels and peak levels, how they correspond with eradication of the organism. That was a weakness. Also, one of the main primary weakness of the study was patients taking inhaled tobramycin. The initial dose was for IV tobramycin, and the inhaled tobramycin serum concentrations did not peak above 0.97 milligrams per liter after the first hour. So the effect of the absorption of the tobramycin inhaled is not effective as other forms of tobramycin, which is IV. So that definitely affected the patients and then the overall results and the endpoint results after the hour of infusion. Well, the target goal endpoints. The primary literature that I use for this was the pharmacodynamics of aminoglycosides, and it used and discussed aminoglycosides and the use of cystic fibrosis and just the background aminoglycosides. Aminoglycosides is a drug that is optimized by peak concentrations by initiating a higher initial dose that's consistent. But it's consistent with adverse effects. So even with the higher dose, you see no significant change between you don't see no significant change between adverse events between the two groups. So a higher dose has been recommended due to the fact of not higher incidence of adverse effects, but also as better coverage and to resist from adaptive and selective resistance. This type of resistance happens if a patient is on continuous tobramycin, like a drip or frequent intervals. Organism being exposed to the drug more frequently has a better chance of becoming resistant. But with the once daily dosing, that drug-free time period allows for the organism not to build resistance to it. But this is why the study was not a success, because the regimen was not effective, and also we don't know if the regimen was effective in eradicating the disease, the organism under that regimen, and that's due to the MIC not being recorded. But besides that, it has been a success for the trial. For future trials, it's given a basis of what to go off of and using demographics between BMI and the pharmacodynamics of the drug and what to expect when treating Pseudomonas aeruginosa. This is Henry, and I really enjoyed this journal club. It allowed me to really relate between the demographics of a patient and drug therapy, because between some patients with this drug, it might be perfect. It'll definitely be perfect if we're reaching the peak. If we want to reach the peak concentrations, and then person with the higher BI, that's what we're looking for. But for the drug to be prolonged in the system, a person with a lower BMI would be more effective to keep it more in the system with the higher trough levels, with the lower trough levels. With the lower BMI, the drug is eliminated quicker and doesn't remain in the system long, which eliminates resistance. Thank you again.